So guys, welcome back to my channel today. So this is the part 2 of the video on gastric cancer. So like we were continuing. So what are the types of gastric cancer? So the most common is going to be adenocarcinoma in 90% of the cases, and rarely you're going to have other types like your lymphoma, which is 5%, then GIST, squamous cell carcinoma, and your signet ring cell type, and your adenocarcinoma, which is less than 1%. Okay. And so this signet ring cell carcinoma, all of you must have heard. So it has poor prognosis. It is a rare variant, but nowadays we are seeing increasing numbers of this type. And usually the cells will contain mucin. Signet cells are going to be seen in this. So basically the cells having mucin with a periphery or eccentric located nuclei will be there. And hence it's called as a signet ring shaped cells, hence the name of signet cell carcinoma. And usually they will be growing like sheet like. Usually they rapidly grow, rapidly metastasize as well, and causes can have some mutational basis like inherent mutations in CDH1 and your APC gene mutation can have it. So let's classify gastric cancers. So you can have multiple classifications. Let's go about one by one. So first we have the WHO classification, in which adenocarcinoma is the most common type. So under adenocarcinoma we have papillary type, the tubular, mucinous, and the signet cell type, which is poor prognosis. Apart from your adenocarcinoma, you can have adenosquamous carcinoma, squamous cell carcinoma, and undifferentiated carcinoma. So this is your WHO classification. Next we have the Lawrence classification. So Lawrence, we have the two types, the intestinal and the diffuse type. Whereas intestinal type is mainly due to environmental risk factors. It is common in males. It is usually blood spread, and microsatellite instability and APCG mutations are associated with your intestinal type. And both the types will have your tumor suppressor gene mutation, that is your P53 and P16 mutations, whereas your intestinal subtype is like risk factors for the same as your gastric atrophy and intestinal metaplasia, and usually will be having a bulky exophytic growth like lesion in case of intestinal type. Whereas when we come to a diffuse type, more common in females, usually the entire body is involved, and it is more familial. Blood group type A is associated with it, poorly differentiated, and decreased E cadherin, so your CDH1 gene. So usually your signet ring cell will be most likely will be in this diffuse category. And so you can have ulcerating lesions. Usually the growth component is less, and mainly ulcers will be there, or there can be some diffuse thickening of the entire body, which is your lindus plastica. So next, coming to your Japanese classification, which is for early gastric cancers. So we have type 1 to 3 in that. One is, as per the diagram you can see, type 1 is a protruded type, and type 2A is like superficial and elevated, slightly elevated. 2B is superficial but flat. 2C is superficial and depressed. And type 3 is your like a ulcer like excavated type. Next you have your Borman's classification. So Borman's classification, again based on your microscopic appearance. So like your endoscopic finding basically. In that 5 types you have. So type 1 is similar to your Japanese type, but it's slightly different. So type 1 is a protruded one, type 2 is ulcerative, type 3 is infiltrative and ulcerative both, and type 4 is diffuse infiltrative. So 2, 3, 4 together are your depressed type, and type 5 is which can't be classified as any of these two. And next we have your molecular classification. So this is basically based on your cancer genome sequencing. So 4 tumor subgroups are there based on your molecular types. So one is positive for your Epstein-Barr virus, which is 9%, microsatellite instability tumors, that is 22%, and your otherwise genomically stable tumors 20%, and chromosome unstable, which is a 50% cases. So chromosome instability, basically you can have your DNA changes like your DNA aneuploidy, translocations, your proto-oncogene, tumor suppressor gene mutations. So those can lead to your chromosome instability. Whereas microsatellite instability are caused by your hypermethylation mutations, and generally will be your intestinal type, as we already discussed, and more located distally, your antral location, and better prognosis. Okay, around 12 to 20% of these CA stomach cases will be HER2 positive and worse prognosis. Next, coming to spread of your gastric cancer. So directly submucosal, along the submucosal plane it can spread directly along the wall. That is your horizontal spread. Vertical is by invasion into the adjacent structures like pancreas, liver, colon, mesocolon. Lymphatic is your all those lymph node stations. We have So this you have to remember the virtuous lymph node, which is also your Trocheus sign, which is your left supraclavicular lymphadenopathy in CA stomach. Okay. Next, hematogenous spread. So from through blood it can go to your liver, lung, bone. All these are hematogenous spread. Transperitoneal is your intraperitoneal. Your peritoneal seeding will be there. Ascites can be there. Krukenberg, that is when it goes to your ovaries. And rectal secondaries, system-adjacent nodules are your umbilical secondaries. Okay, so this diagram is showing your lung and peritoneal mets. So next, coming to your TNM classification. So this is your 8th edition TNM classification. So recently 9th edition has come. So 9th edition also is similar to this, not much changes. So in this we have T, N, M, M and G as well. So G is your grade in which 1, 2, 3 well, moderate, poorly differentiated. Whereas M is your metastasis, M0, M1 respectively for no and with mets. And so coming to T and N stage. So T and N both have an X stage, which is where it cannot be assessed. TIS is your in situ. T1, 2, 3, 4. T1 is based on your how much invasion. So T1A, T1B. T1A will be your lamina propria or muscularis mucosa. So that is your early cancer. T1B is submucosa. T2 will involve the muscular layer. T3 is your serosal, subserosal connective tissue layer and the visceral peritoneum. And T4 will have A and B. A is the visceral peritoneum serosa. So T3 usually no visceral peritoneum invasion. T4A will have visceral peritoneum invasion and T4B will be your adjacent structures. Whereas your lymph nodes are based on the number of lymph nodes involved. So N1 is in 1 to 2 lymph nodes, N2 is 3 to 6, N3 is more than equal to 7. So again N3AB is there, N3A is 7 to 15, N3B is 16 or more regional nodes. So how does CA stomach present? So you can either have asymptomatic in early cases or later on you can have some indigestion, vomiting, vague discomforts, and if there is significant mass distally which is causing obstruction, then you can have gastric outlet obstruction symptoms, vomiting, abdominal distension. Next, so metastatic disease depending on your where it has metastasized. So liver can have abdominal pain, jaundice, bone can have bony pain, back pain, lung can have cough, breathlessness, and likewise ascites can have abdominal distension likewise. So this is a diagram showing your umbilical nodule, that is the sister marriage of Joseph Metz, and your Trocheus sign. So is there any role of screening in gastric cancer? So early, obviously gastric cancer important is early detection, because advanced stages often will metastasize and curative treatment may not be possible. However, screening is not practiced or not possible in India currently because of the heterogeneity of population and such a large population, and difficult to place a screening program. However, some countries like Japan etc. have screening program for CA stomach. So in case we had to screen, how would you screen for CA stomach? So we have some 3 tests. One is a pepsinogen serum test, which will help to find out. So low PGI concentration or a PGI 1-2 ratio. If there is a low ratio, they are good indicators of atrophic gastritis, which is your pre-neoplastic lesion. Then gastrin 17 serum levels. Again, this is for distal stomach, so not much utility as a single marker. And we have variant studies for gastric cancer screening which has been used in Japan. Most important is your endoscopy, so which is like the detection rate is around 2 to 5 times higher than your routine fluoro or your barium studies. Again, it is operator dependent, skills are important, you need an endoscopist, and mass screening may not be feasible. Okay, so next just briefly about narrow banding imaging. So narrow banding imaging is your part of your endoscopic screening, so wherein we use 2 different wavelengths of light. So you use your blue and your green spectrum, which have variable penetrability, based on which you can see the pattern of your capillary vasculature coils, based on which you have 3 different patterns, pattern A, B, C, wherein C pattern corresponds more likely with your dysplasia. So this is a little complicated, may not be possible to implement in screening programs. Okay, so next let's come to management. So this is in brief the treatment algorithm for your management. So initially comes with symptoms, then you do as investigation we usually do a contrast CT of the thorax, abdomen and pelvis to rule out your lung mets, etc. Metastatic workup happens in that. And for CA stomach, which seems to be operable, we usually also do a lateral decubitus view just to see the planes of the growth of stomach from the head of pancreas. Okay. Apart from that, we will be doing upper GI endoscopy, so to map the exact location of the growth. So, and also we will be taking biopsy in the same sitting to confirm our diagnosis. So now we have a diagnosis of adenocarcinoma, and then we have to give nutritional support to the patient, which is very important. Patient able to take oral adequately, then to encourage oral feeds. Otherwise, we might have to put a gastric bar nasojejunal tube depending on the site of the growth to bypass the growth. In case patients having obstruction, vomiting, then a nasojejunal tube might be better for nutritional support. So we need to nutritionally build up as well as start them on chest physiotherapy, etc. And so early localized T1, T2 cases, selected T1 cases, T1A, T1B cases, we can do an endoscopic treatment. So endoscopic submucosal resection bar, endoscopic mucosal resection bar, endoscopic submucosal dissection, ESD-MR can be done. Or early T1, T2, you can even do a D2 gastrectomy. Next, otherwise T3, T4 is local regionally advanced or node positive also. So generally we give neoadjuvant chemotherapy and then we reassess for surgery. Any metastatic disease will automatically become palliative, so we give palliative systemic therapy. And palliative care, we also can consider endoscopic stenting if there is any gastric outlet obstruction to bypass the growth, so which can improve quality of life for the patient. So I will come to the chemo, radiation, etc. in detail. So workup I have already discussed. PET CT. So PET CT, actually PET CT, like in recurrent cases you can consider for PET CT. Upfront you can go ahead with the CECT, thorax, abdomen, pelvis, that is sufficient. And often PET CT will not pick up or may not pick up signet cancer cells because they may not be FDG avid. In that case we might need a FAPI PET. So that is about PET CT. So smoking cessation is very important. So there was a trial called Monicon trial which has shown that there is no adverse effect of stopping chemotherapy early in non-responders. PET responders had better survival as per this trial. So PET can also be used as a like response monitor also. And FDG avid tumors overall had lower survival. So next coming to endoscopy. So endoscopy, so staging evaluation. So if you do an endoscopy combined with an endoscopic ultrasound, so it is very accurate for your T and your N staging, especially for your T staging. N staging is 70 to 100% sensitivity and T stage is 64% sensitivity.